Good afternoon, dear Professor Mebata, Dr. Arenya, dear audience. My name is Hatice Gerhard, and I'm a research fellow in the group of Basel PMI from Switzerland. And today I would like to present you my thesis with the title Incidence and Outcomes of PMI Diagnosed with Sensitive Cardiac Troponin I. Next slide. I will just talk on. Some background information. So why is this study necessary? Although PMI, thank you. Yes, thank you. Although PMI is known as a perioperative complication and its outcomes were documented several times, there is no consensus definition of PMI. A contributor of this problem is that large cohort studies were giving us guidance for cutoff values using often high sensitive troponin assays. But there are a number of other studies, they are using different cutoff values, different assays. So in this pool of heterogeneous informations, the role of sensitive cardiac troponin I is lacking and made this study for us necessary. Our aim was to look at the incidence of PMI detected by a screening program with sensitive cardiac troponin I and look at the mortality and MACE associated with PMI. Let's look at our patients. Who did we include? We included patients who had a non-cardiac surgery at the Cantonal Hospital Aarau, which is in Switzerland, and we included patients with increased mortality risk. So they were older than 65 years or 45 years with a history of coronary artery disease, peripheral artery disease, or stroke undergoing non-cardiac surgery, and they had to have a stay after the operation for at least 24 hours. And we excluded patients with improper screening indications, for example, when they had cardiac surgery within the last 14 days. In our statistical analysis, we wanted to look at the incidence of PMI, and we used the 95% confidence intervals by Agresti and Cole. And to look at the association of the patients with PMI for the outcome mortality and MACE, we did a survival analysis with Kaplan-Meier curves. And in our multivariable regression analysis, we wanted to look how much is PMI as a predictor, how much has it a role on death and MACE as the dependent variables. Our primary endpoint is the incidence of PMI, where the definition with our used assay, the Siemens Dimension Vista, is an absolute increase of 45 nanograms per liters, which is the 99th percentile of this assay. Our prognostic endpoints were MACE, which was a composite of acute myocardial infarction, acute heart failure, life-threatening arrhythmia, and cardiovascular death, and all-cause death. Let's look at the numbers. In the beginning, we had 2,076 patients, and PMI occurred approximately 10%. When we looked at which were cardiac PMI and non-cardiac PMI, there was a clear difference. We had 93% of cardiac PMI versus 7% of non-cardiac PMI. When we looked at the medical record, what these patients told us, only 4% of them said that they had typical chest pain. And I mean, there are other ischemic symptoms like, for example, dyspnea or atypical symptoms. When we looked at them, they were 15%, and only 2% of them had any ischemic imaging changes. So we were interested how many of our PMI patients did fulfill additional criteria for spontaneous AMI, and there were 26%. But what does this mean? Does it even matter when we look at the outcome death after a year? And you can see in the blue line, this is PMI fulfilling additional criteria, and in green, PMI not fulfilling the criteria. And those two curves are not significantly different. So there was not major variety when we looked at mortality at the end of the year. When we look at all-cause death after a year and compare PMI with no PMI, then the all-cause death was twice as high compared to no PMI. In the group with PMI, there was 90% of the patients with PMI died versus 8.3% in the group of no PMI. This comparison is comparable when we look at MACE after a year. And now let's look to the survival analysis we did. On the left side, you see the cumulative mortality after a year. And here, the curves are significantly different. In red, you see the patients with PMI compared to the patients with no PMI in blue. And the same is for MACE on the right side. It's also significantly different. And we did the multivariable regression analysis to look how much is PMI a predictor for those variables. We adjusted them for age, non-elective surgery, revised cardiovascular risk index, and some post-operative complications. Our adjusted hazard ratio for cumulative mortality was around 1.9. And for MACE, was it around 3. What were our limitations? As I said in the beginning, we have no universally accepted definition of PMI, which makes it a little bit challenging, and we only had high-risk patients. Screening and treatment, which we did actively, might positively influence mortality and the occurrence of MACE. At the end of my presentation, I want to highlight some of our results. PMI occurred in almost 10%, and only 4% had typical chest pain, so we can imagine that diagnosing them is challenging. All-cause death after 1 year in patients with PMI versus without PMI is twice as high. Our conclusion is, using sensitive cardiac troponin I with this assay, PMI remains an independent predictor of all-cause mortality and MACE. Thank you very much.
Thank you very much. Is there any question? Please.
Hatice, very good presentation. Thank you. Thank you very much.
Thank you.
I'm just wondering which is the role of diabetes in predictions of the incidence of perioperative myocardial infarction, because is it that diabetes is causing no symptoms? So could you please tell us which is the value in your cohort of patients with diabetes? Did you analyze that?
When I look at the baseline characteristics, which I didn't show, then it is was it clear that it was higher in the PMI group? But this counts also for other cardiovascular risk factors. This was really clear, so we didn't show.
So the influence of diabetes was not more relevant compared to the other risk factor? Diabetes
for
was...
For PMI? Sorry?
No, I mean, in the cohort of patients
yes.
that got myocardial infarction perioperative setting,
yes.
The incidence of diabetes was higher compared to patients that had not? Yes or no?
I didn't check diabetes. Also, in the population of PMI versus no PMI,
yes.
It was higher, yes.
Oh, that's important.
Yes, it was
I
higher.
think this is something that we should
yes,
definitely...
when I compared it, yes, it was higher.
And the second question, if I can, could you think that in detecting high-sensitive troponin before making the intervention in these patients at risk with diabetes should be of utility in order to predict and avoid the increased therapeutic approach? Because this is really important. To understand which patients can develop increase in high-sensitive troponin. Could you speculate that you can detect high-sensitive troponin in diabetic patients before doing this? Do you think is important, or I don't know, but should be probably something we should work in the future.
It's just a speculation,
Yes.
but I think you can speculate that because but not always, but sometimes there are like typical patients for that. That's also why we look at the our inclusion criteria in Basel. We later on put the diabetes patients in, but this was an earlier
Okay.
cohort.
Thank you.
Exactly.
Thank you very much.